Hi, this is Dr. Bhargava, and this is the next video in the series Body Imaging Case Review. Here is our first patient, and they presented with chest pain and a coronary CT angiography was performed. And here we are looking at images from that study where we want to focus here on the LAD. Coronary arteries are epicardial in location and they're surrounded by epicardial fat, what we see here. And sometimes we see what we call myocardial bridging, where especially the LAD dips down into the myocardium right here, more distal to this level. And then more distally, it further appears back into the epicardium. So myocardial bridging is a condition where a part of the myocardium is bridging over superficial to the epicardial location of the coronary artery. And when this myocardium contracts during systole, there is a potential of compromised blood flow to the distal territory of this coronary artery. So this patient was diagnosed with myocardial bridging. Here are some other images. On this axial image, we find this is the LAD and it is in the myocardium. This is the right ventricle, here is the left ventricle, and we see some myocardium around the LAD and not epicardial fat. This is also seen right here on the reconstruction and probably somewhere here. So this patient was diagnosed with myocardial bridging. Here's our next patient. We performed an MRI of the pelvis to stage their rectal cancer. I'm showing you small field of view T2 weighted images in all three planes on the top, and then at the bottom we have post-contrast images and another T2 weighted axial image where we can see that there is the tumor inside the rectum, but the muscularis, which is generally the black line on a T2 weighted image on the MR, is preserved. Here we find that the black line is interrupted right here and the tumor is growing out of the muscularis and involving the surrounding mesorectal fat and has involved the mesorectal fascia also, as we see right here. On the coronal image, we find a similar finding of tumor extension beyond the muscularis, and on the sagittal we see the same. The tumor is circumferential. All of this right here, the mural thickening that we see in the rectum, is the tumor. From here, distally, the lower rectum and the anal canal are normal. These are contrast-enhanced images here showing a hypo-enhancing tumor, and we are at the same level as the axial T2 weighted image, extending through the muscularis to involve the mesorectal fascia on the right side. And here is a corresponding post-contrast sagittal image showing the tumor. So staging is why we perform MRI for rectal cancer, and the findings that I showed you will make this tumor a T3 stage for T staging with mesorectal fascia involvement. This is our next patient, and they presented after aortic valve replacement with signs and symptoms of endocarditis, and a CT scan was performed. And here on the CT we see these vegetations on the inside of the replaced aortic valve, also seen right here. And so the patient underwent FDG PET-CT for further evaluation. This is a vegetation as well. We will start by looking at the rotating image from this whole body FDG PET-CT. We find that there is physiologic distribution with most intense uptake in the brain, followed by excretion from the kidneys into the urinary bladder. For some reason, the spleen is more active than the liver. Normally, the liver is more active than the spleen. There is this intense uptake in the esophagus. Looks like they've had some surgery involving the stomach. The appearance is not normal, and the increased uptake suggests esophagitis and gastritis. The important finding is seen right here at the site where we saw earlier on the CT vegetations. There is focal intense FDG uptake, and this suggests endocarditis or infection of the vegetations seen at the site of the prosthetic aortic valve. So FDG PET-CT is a great modality and an emerging modality to evaluate infections of prosthetic aortic valves, and we have a great example here of that. Here is our next patient, another patient with rectal cancer, and I'm showing you just the T2 weighted images in 3 projections. We have axial, coronal, and sagittal. On the axial image, we find that the tumor is extending posteriorly right here from the rectum to involve the prostate. The T2 hyperintense part here is the peripheral zone of the prostate, and it is involved by the tumor. This is the tumor involving the prostate, and here we see the same finding on the sagittal projection. So when regional organs are involved, the T staging is T4, like in this patient where there is involvement of the prostate from the rectal cancer. And the same patient underwent a whole body FDG PET CT for whole body staging, and on this rotating image, we find the hypermetabolic tumor in the lower rectum, and we find FDG avid metastatic disease involving the lung nodules. We see one here, there is one right here, and there are other metastatic lung nodules in both lungs. So this patient has stage 4 rectal cancer with lung metastasis. This is our next patient, another MRI of the pelvis, this time in a female patient to evaluate an incidental finding. So on the sagittal, axial, and coronal small field of view T2 weighted images, we see this simple appearing cystic focus T2 hyperintense in the perineum deep to the wall of the left side of the vagina. And on the contrast enhanced images, we find that there is no contrast enhancement. There is T1 hyperintensity inside the cystic focus, suggesting proteinaceous content. And we have here on the bottom right ADC image showing high signal, which suggests no restricted diffusion. So there is no pus inside, and there is no evidence of malignancy. So this is an example of MRI appearance of a Bartholin gland cyst. Here is our next patient. They underwent an MRI of the abdomen. They were suspected of having a neuroendocrine tumor, and they were initially evaluated with CT. On the MRI, we are looking at pre-contrast, then post-contrast, and delayed contrast-enhanced images where we find that this is the tumor in the body of the pancreas, which shows arterial phase contrast enhancement, and it shows enhancement on the delayed phase as well. We know that in terms of solid tumors arising from the pancreas, they can be divided into 2 categories. The ones that enhance, they are or tend to be neuroendocrine tumors, and the ones that do not enhance are more ominous pancreatic adenocarcinomas. And here at the bottom left, we have axial T2 weighted image showing that distal to the tumor, the pancreatic parenchyma is atrophic and the duct is dilated. That's where the tumor is. And on the further right, we have DWI image showing high signal and ADC image showing corresponding low signal, confirming restricted diffusion in this neuroendocrine tumor arising from the body of the pancreas. So this patient would need a DOTATATE PET CT for whole body staging, and here are the images from that scan. We will start by looking at the rotating image where we see this physiologic uptake in the pituitary, we see focal intense uptake in the tumor, and then we see physiologic increased uptake in the adrenals. So let me show you those findings on the cross-sectional images. This is the tumor with intense uptake of DOTATATE. Then we have physiologic uptake in the left adrenal and physiologic uptake in the right adrenal, which should not be confused with a tumor. Here is our next patient, and here I'm trying to show you a normal variant from a coronary CT angiography where we normally see LAD arising from the left aortic cusp and dividing into the left main arising from the left aortic cusp and dividing into the LAD and the circumflex arteries. A lot of times we see trifurcation where there is LAD, circumflex, and the ramus intermedius arising from the left main. Here, both the arteries, the LAD and the circumflex, are arising directly from the left aortic cusp, and there is no left main coronary artery. best seen here in these reconstructions. So a normal variant where there is absent left main coronary artery and the LAD and the circumflex arise directly from the ascending aorta. Here's our next patient. They were diagnosed with neuroendocrine tumor arising from the duodenum, and we performed a DOTATATE PET-CT for whole body staging. And on this rotating image, we find that the liver is enlarged and has all of or multiple photopenic defects inside the liver. And on cross-sectional images, we find that here is the mass in the duodenum that does not take up DOTATATE. A stent has been placed so that food can pass without any obstruction in the region of the tumor. Further images show that there are multiple tumors in the liver that do not take up DOTATATE. There is a focus of bone metastases, sclerotic focus with mild uptake in the right proximal femur, and there is also a subcutaneous tumor deposit seen in the left buttock. So they have a metastatic neuroendocrine tumor which is not DOTATATE avid. So this will be a high-grade neuroendocrine tumor not taking up DOTATATE, and in this situation, if you do an FDG PET-CT scan, there will be intense uptake in the tumor. Here is our next patient, and they received treatment for colon cancer, and they presented with rising ctDNA, and we performed an FDG PET-CT scan. On this rotating image, we find that there is focal hypermetabolism seen in the liver, and that focus corresponds to this finding seen on the cross-sectional fused images. And there are two more images from their diagnostic CT showing this hypodensity on a contrast-enhanced scan. And so ctDNA is more frequently now used to look for recurrent or metastatic disease in patients who have colon cancer, and when the ctDNA is rising or positive, then we want to do an FDG PET-CT scan to find where the tumor is so that they can receive more or further treatment. Here is our next patient, and the reason for the scan was undescended testis. I'm showing you this coronal image a little bit more anteriorly to show you the inguinal canals on both sides and how they are empty, and we don't see any vessels going down into the scrotum that supply the testis. So the testes are absent in the scrotum, and on the cross-sectional images more superiorly, we find that this is where the left testis is lying in the intra-abdominal location, and this is the right testis at another level in the pelvis in the intra-abdominal location. So undescended testis are generally atrophic, and they are at risk for developing seminomas. This is our next patient, and here we have a tumor that is arising from the adrenal. And so on this image, I'm trying to show you that the tumor, which we see right here, a complex cystic mass, is separate from the right ovary, and we see the same finding here. It's abutting, the right kidney. It's abutting the right kidney, but it's not arising from it, and it's also not arising from the liver above, and so it's an adrenal tumor. It's a large complex cystic mass with some peripheral tissue that shows enhancement, and so these findings are consistent with an adrenocortical carcinoma. This was removed by surgery and proven to be an adrenocortical carcinoma. Here's our next patient. They presented with menorrhagia, and on the MR pelvis on the top we have small field of view T2-weighted images in sagittal, axial, coronal, and axial projections. There is a enhancing focus, which we see right here, arising from the anterior myometrium and growing towards the endometrium. So they have a polypoid fibroid, which is also seen right here and right here, which is probably the cause of their symptoms, and this can be described as a polypoid or a submucosal fibroid arising from the anterior myometrium and with mass effect on the endometrium. This is our next patient. We performed a whole body bone scan to stage their breast cancer. On these anterior and posterior whole body images, there is no evidence of osteoblastic bone metastases. A representative image from their CT chest shows this large mass in the left breast in the lateral aspect. The entire breast is not in the field of view because it's a large patient. The interesting finding here is that there is some hyperemia or hyperemia related uptake of MDP seen in the left breast tumor and also in the left breast skin thickening. So remember, tumors have increased blood supply, and because of that hyperemia, there can be increased delivery of technetium-99m MDP, and we can see that faint increased or asymmetric uptake, especially when compared to the other side. Here is our next patient. We have performed a multiphasic CT of the liver, and on the left we have the non-contrast enhanced image followed by the arterial phase, portal venous, and delayed phase. The tumor is seen right here in this region as a hypodensity. The liver has a nodular contour suggesting cirrhosis. We know that in cirrhosis, there are two common tumors. The more common one is an HCC. The less common tumor that arises in cirrhotic livers is a cholangiocarcinoma. HCCs show uniform enhancement in the arterial phase, which we do not see here. There is some faint continuous peripheral enhancement. And on the more delayed images, it seems like there is a fill-in from outside to inside with this appearance seen on the most delayed image. And so these findings are characteristic of a cholangiocarcinoma. This would be given an LRM, M for malignant or malignancy, when you are using the Leirat's criteria to describe this tumor. This is the same patient. They underwent an FDG PET-CT scan. Cholangiocarcinomas are FDG avid, so the tumor is lighting up here, and also at the hepatic hilum there is a enlarged lymph node with central necrosis, peripheral hypermetabolism consistent with metastatic disease from the cholangiocarcinoma. This is our next patient, and I'm showing you two images. The left image is an in-phase image, and the image on the right is the out-of-phase image from their MRI. And from in to out of phase image, there is signal drop in the liver, and when that happens, we know that the liver is steatotic, and here there is a lot of signal drop from the in to out of phase image suggesting severe hepatic steatosis. This is our next patient. They presented with a lump on their left lower back, and an ultrasound was performed. And so there are two images from the ultrasound showing here a hypoechoic focus that is subcutaneous in location with some internal debris. No color flow was seen on the color Doppler images. And on one of the images, if small connection is seen with the skin above that lesion, and so that makes it an epidermal inclusion cyst. Here is our next patient where an ultrasound was also performed for suspected ectopic pregnancy. On the top left, I'm showing you the uterus with the endometrium, and there is no evidence of a gestational sac inside. Next, I'm showing you the ovary on the right side, normal in size. Ovary on the left side, also normal in size, and no suspicious focal lesions in either ovaries. There are some developing follicles seen bilaterally. Then the images, some other images were submitted by the technologist. Here, this image is labeled long axis view adjacent to the left ovary. They see this ring-shaped focus with a thick wall, and inside they are able to find a yolk sac, and also they were able to measure a fetal pole. And so this is the gestational sac. Inside it, we see the yolk sac and a fetal pole, and this is a great example of an ectopic pregnancy. This is our next patient, and we performed an FDG PET-CT scan to evaluate suspicious findings in the left lower lobe of the lung. On the rotating image, we find physiologic distribution with no focal intense uptake to suggest FDG avid neoplastic disease. On the cross-sectional images, we find that there is faint uptake in this part of the left lung, which appears collapsed, and there is adjacent to it a small left-sided pleural effusion. and here it's the same image in the lung windows shown right here. So FDG PET-CT is a good modality to evaluate if there are any underlying lung masses where anatomic imaging shows just lung collapse or atelectasis and an underlying mass cannot be ruled out. So here, because there is no focal hypermetabolism, the finding that we see on the CT is just from the collapsed lung or atelectasis secondary to this pleural effusion, and there is no FDG avid tumor. Okay, so coronal CT images on two different patients on this next slide. The image on the left is an abnormal image. The image on the right is normal. So let's start with that. Look at the mucosal pattern in the proximal small bowel loops in the left side of the abdomen and compare that to the mucosal pattern on the right side. The folds are more prominent and they're more closely placed in the proximal small bowel compared to the distal small bowel. And now look what happened here in the proximal small bowel compared to the distal small bowel. There is a reversal of mucosal pattern between the proximal small bowel and the distal small bowel, and that suggests a diagnosis of celiac disease. So look for it, and then when you find it, it would be helpful in patient management. This is our next patient. They presented with abdominal distension. We performed a CT of the abdomen and pelvis. On this axial image, we see cirrhotic liver, large volume ascites, some portosystemic collaterals, and then a large fluid containing right-sided hydrocele, a communicating hydrocele, and then the fluid has also gone through a umbilical hernia and it's protruding outside the abdomen seen right here. So multiple findings all related to cirrhosis and ascites. Thank you for watching.